Hi, good morning. My name is Roshanak. I'm a graduate Grace and I'll give the EMCCM talk today.
Just hover the mouse over.
This is,
Yeah, just click. Yep. Thanks.
I would like to thank the EMCCM team and Dr. Wiener for giving me a lot of good feedback. So this is a case that EMS was called for overdose. A 55-year-old male found ambulating in the scene after his wife called EMS because the patient took all of the medication that was in their medication cabinet. They found the patient to be alert, oriented, only complaining of some abdominal discomfort, saying, "I want to go to heaven, why did someone call the police?" Actually suicidal. Vital signs on the scene were remarkable for tachycardia, otherwise normal finger stick glucose was 156. On arrival to the ED, patient was borderline tachycardic, blood pressure was within normal limits, however, it's decreased from the vital signs that were recorded at the scene. Patient was alert and oriented, in no acute distress. It's also worth noting that the patient arrived to the ED around 17 minutes after that first call to EMS and around an hour and a half to 2 hours after the ingestion happened. So I'm going to skip through some of the slides just because we're running a little late. So the primary preliminary problem is we have a patient that has suicidal ideation, has a toxic ingestion of multiple medications probably, is borderline tachycardic, is getting hypotensive. So on arrival, patient was placed on cardiac monitor, received 1 liter of IV fluids, 12 EKG was taken, and also finger stick glucose was checked. And then the team kind of moved on to talking more to the patient, assessing the patient. So chief complaint is that I have a lot of problems, I take a lot of pills. It is recorded in the HPI, the patient, 55-year-old male with intentional amlodipine overdose. He says he wants to go to heaven. Also, of note, patient is on metoprolol, statin, and buspirone. It is not clear if patient also took those medications as well. However, it is the part that's more clear is that amlodipine was definitely taken. Has medical history of coronary artery disease, hyperlipidemia, hypertension, anxiety, denies any ETO issues, smoking or other or drugs. A patient appears well developed, speaks in full sentences, no acute distress, no signs of trauma, pupils are reactive, neck is supple, chest and cardiovascular and lung exams are normal. Abdomen is found to be non-distended, not tender, soft, but has decreased bowel sounds. On extremities are warm, however, the pulses are weaker and there's no other findings. Patient is awake, is alert, moves all the extremities, sensation is intact, and has active suicidal ideation. This is the 12-week EKG. If I can have one, the junior's shin in the front.
He sits there because he wants to answer all the
Huh?
questions.
That's true. All right. So
What do we think about this EKG?
my gestalt is it looks poopy. So my first thought is it looks abnormal, but
Let's go from like, is it sinus?
oh yes, it's sinus. I was just counting the 16 times 6. So
Yeah, the rate of around 100.
yeah, so rates around 100. There's a P for every QRS complex. The axis is upright and 1 in ADF, so it's like on a normal axis. Then I guess.
What do you think about the PR intervals? They look pretty normal to me.
Maybe like a little bit of, maybe a little bit like prolonged-ish.
Prolonged. The QRS is fine.
Yeah, it's like a little
The
bit
better
better
side?
than 3 boxes.
Yeah. And then the QT
I mean, it's like about halfway.
looks normal.
It's like I would say like borderline normal-ish,
Okay.
but.
Okay, so great. So we have a sinus rhythm, rate of around 100. PR interval is normal. I know it's hard to maybe see from there. The QT interval is normal. There's a the QRS is white. Looks like a left bundle branch block pattern. So in general, looking at the EKG of somebody with intoxication, the things that we want to look for specifically in this patient that definitely took amlodipine, maybe we also took some beta blockers, is just starting from the beginning. The rate is important. If the patient is bradycardic, it can be from beta blockers or calcium channel blockers. However, in this case, the patient took amlodipine, which is has vasodilatory effects and with less effect on SA or AV node. So we expect these patients' amlodipine intoxication to be more on the tachycardic side because they're hypotensive and they can have reflex tachycardia, whereas in beta blocker toxicity, you can have bradycardia, you can have prolonged PR, which you can also have with some calcium channel blocker toxicities, such as verapamil, diltiazem, but less with amlodipine. And then you want to look at their QT intervals and the QRS segments. So the QT, the QRS widening can be from sodium channel blockers or calcium channel blockers. However, the pattern is a little bit different in sodium channel blockers. If you see on the right side top, that is more suggestive of sodium channel blocker toxicity. You see a terminal R wave in the AVR, which you don't see in this patient, which is this ones on the left is the patient's EKG. And then you want to look at the QT. The QT interval in this patient is normal. However, in the patient with prolonged QT interval, you can think of, again, sodium or potassium channel blocker toxicities. And also you can look for like specific patterns, like the one on the right bottom, which is curved SD segment depression, which you see mostly in just toxicities. So I'm going to skip over these a little bit because we're running a little bit late. So the initial EKG is basically left bundle branch block, doesn't have no sinus rhythm, normal rate of 100. So on reassessment, patient has a blood pressure, that is going down and heart rate of 93. Patient is still alert and oriented. These vitals are interesting to me because despite the blood pressure is going down, the patient is not getting tachycardic. So that reflects tachycardia, the expected amlodipine toxicity is not fully there. This might be because patient is at baseline on beta blockers, or might be because that they also ingested a bunch of beta blockers with the calcium channel blocker. So at this point, the decision is made to basically treat the patient for calcium channel blocker toxicity. Calcium is started, given 2 grams, methylene blue is given, and also patient is started on peripheral levofat due to blood pressures kind of dropping. Some blood work is sent. There is also very remarkable the things to check in these patients is obviously ethanol level, acetaminophen level, salicylate level. The calcium channel blocker levels are available in some hospitals. However, there is research showing that the level of the calcium channel blocker in blood doesn't really correlate with the clinical picture. So they're less, I guess they're useful to know if the patient took them or not, but they don't necessarily correlate with the.
Quick question. Why did the patient why did they give methylene blue so early?
So I think at this point, the decision was made that the patient primarily had a calcium channel blocker toxicity. So they were kind of like ordering all of the medication
insulin.
So we will get to that. They were thinking about insulin, and actually some orders for insulin were placed, but they were not given because it was a long time between this time and the time that they could actually get the insulin going. So they did it. I'll get to that.
Well, basically, because the pharmacy was having problems mixing, which is a very important point, is we gotta try to address it. It took hours for them to get proper concentration.
So like insulin was ordered around like between hour 1 and hour 2, and an hour and a half into the patient was in the ED, even before poison control was consulted. However, it was a lot of like barriers getting the insulin from the pharmacy, especially in large doses, and we'll get to that. But at this point,
surprisingly, no barriers to get methylene blue.
Yeah. So the medication that they could get immediately, they gave it. So the thought process right now is calcium channel blocker toxicity.
What about glucagon?
So
that
well, that was not given at this point. That was actually given further down the road in the MICU, which we'll get to. But no, that was not given either. So the interventions at this point is starting the patient on peripheral levofed, giving some fluids, methylone blue, and calcium gluconate 2 grams. The blood work is very normal. What is interesting here, again, that thought process of beta blocker toxicity versus calcium channel blocker toxicity. The glucose level can help a little bit. Most calcium channel blocker toxicities can have hyperglycemia or normoglycemic. Beta blockers tend to be more hypoglycemic. So between hour 3 and 4, patient was getting more and more hypotensive. I don't have the exact numbers because in the ED vital signs, the documentation was really poor. However, talking to the providers that saw the patient was getting more and more hypotensive, but is still alert, ventilating well, is a norepinephrine. They're increasing the dose of norepinephrine, and the decision was made to place the central line and start the patient on second pressors. And around this time, again, insulin is ordered, but it's not given yet. This is the EKG. This is the chest X-ray after central line placement, the placement. At hour 4, a poison control is called. They recommend a high dose insulin, 1 unit per kg per hour, with glucose, and also to monitor and replace electrolytes, this is PRN, and give charcoal if bowel sounds are present. So it takes another hour to really set this up, and at hour 5, patient receives the 72 units bolus of regular insulin, and then is started on the drip 1 unit per kg per hour with the 20 infusion. Charcoal is ordered. It was actually ordered a little bit before, but it's not given. It's not given until hour 6. There were some questions about giving charcoal or not, given that the patient has decreased bowel sounds. It was not completely silent, but the bowel sounds were decreased. The patient was complaining of some abdominal discomfort and a little bit of nausea. And so there were a little bit of a question of giving the charcoal or not by the primary team. However, at hour 6, patient receives the charcoal, get a liter of IV fluid, potassium is circulated, and patient is at this point admitted to MICU. So just to summarize the AD course, the timeline of the AD course is as follows. So before moving on to what happens in the ICU and after patient's admission, so here again there is a point of like beta blocker toxicity versus calcium channel blocker toxicity, or just calcium channel blocker toxicity on somebody that is a baseline on beta blockers. At home, I'm specifically going to go over calcium channel blocker toxicities in terms of like treatment. Like any other toxicity, it's important to try to determine how much medication is taken. You can try to, if the patient is stable enough and you have time or somebody has time, the pharmacy can be contacted, try to get the history of was it long acting versus sustained acting versus short acting, how many medication was taken. In this case, they determined that the patient took a maximum of 300 milligrams of amlodipine, which is a very large dose, because toxicities are even like reported like 30 milligrams of amlodipine. But that was the amount that was at the disposal of the patient was 300 milligrams. So potentially that's the amount that he might have taken. There is other meds that the patient might have taken, including metoprolol and buspirone. Buspirone is less of a concern because usually only causes some GI upset and some dizziness. Patient wasn't really dizzy and had some GI upset. And we talked about beta blockers to some extent. Another point about beta blocker toxicity is that they can have more CNS depression than calcium channel blockers, and calcium channel blockers generally don't create CNS depression in isolation. So this patient was learning-oriented, which points more towards calcium channel blocker toxicities, and then the EKG findings that we discussed. So these are the points I'm going to go over. So the way calcium channel blockers work is by blocking calcium voltage-gated calcium channel in the myocardium and vascular smooth muscles. And in general, under normal circumstances, non-dehydroprotein calcium channel blockers or optimal deltiazar mostly act on the myocardial cells and also they can act on the SA and AV nodes. Dehydroprotein calcium channel blockers, amlodipine, tadipine, they work mostly on vascular smooth muscles and mostly cause vasodilation. However, in intoxication, some of this selectivity is lost. So at least theoretically, both type of medication can cause both of the effects. The other effects of calcium channel blockers is that they inhibit release of insulin and they can cause hyperglycemia. They can also reduce cardiac glucose utilization, and also insulin by itself is shown to have some effect on the contractility as well, regardless of glucose metabolization. So this is another effect of calcium channel blockers. So as we can all see up to now, calcium channel blocker toxicities are very complex. They're highly lethal, and the treatment is based off some little evidence here and there, and it is changing a lot. So it's very important to call poison control early. In this case, the thought of calling poison control was there from the beginning, but the call was actually made a couple of hours later, apparently because there was some confusion of who has called poison control. If one of the providers thought the other provider has called, but the thought was there, but the poison control was called a little bit later in the process. You can also talk to your local toxicologist. This is Dr. Wiener's cell phone number. He asked to be texted or called in real time. We have this resource here. We should be using it. You can phone a friend. In terms of initial management, obviously, every come first. The patient has CNS depression, they are not protecting their airway because they took a bunch of other medication or were so hypotensive that they are altered. You need to protect their airway. However, if you do have time, just be mindful that these patients are usually very hypotensive and get more and more hypotensive as it goes. So just intubating them, putting them on public pressure ventilation might decrease their, yes.
I mean, just going to that, like you presented 2 hours, under 2 hours presentation time, right, after ingestion?
Around, yes, about 2 hours.
But getting airway might also allow you to do lavage.
Yes, but so just be mindful that these patients are very hypotensive. So if you have time having some resuscitation on board, so to kind of support their hemodynamic status before intubating them is better. There is not much evidence basically supporting intubating them just to giving them lavage. However, if you do happen to intubate them for other reasons, this also presents an opportunity to do GI decontamination, which we can get to. On history, again, you want to get the time of ingestion, maximum possible dose of ingestion, other ingestions, formulation of ingestion, immediate versus sustained delays. You want to ask about co-ingestions, especially with beta blocker and drugs. These are usually older patients. There are multiple medications at the same time, and also patients' medical conditions. In terms of labs, we discussed it to some extent. Urine tox is not very useful, like in any other toxicity. In terms of treatments, before getting to specific treatments, the evidence behind most of these treatments is very weak, mostly from animal studies, case series, case reports, some observational studies here and there. Comparative treatment studies between two different treatment arms are very rare, and often more than one intervention was on board at the same time. What happened here? This is not showing. It is, yeah. Sorry. Okay, so why is that? If toxicologists, as we know, are some of the smartest people among us, why are these evidence so weak? Because the reason I think of this is that when we think of good interventional studies, we are thinking of controlled setting, we are thinking of blinding, and we are thinking of randomization and giving placebos. And none of that is really possible in toxicology research. How are you going to consent a suicidal, critically ill patient with multiple ingestions? You can't really control for ingestions. You can't really control the time of ingestions. You usually have to have multiple treatments on board, and it's really hard to do, let's say, a randomized control trial in these patients. They rarely happen in isolation. And then because a lot of this is from case reports, you have obviously publication bias here as well. So as far as individual treatments, activated charcoal is something that can be used. In general, for overdoses, you want to use activated charcoal when the intoxication, the poisoning is recent, is deadly. There is no antidote for it, or in case of sustained release medication. Calcium channel blockers kind of check all of those boxes. So if the patient is presenting within 1 to 2 hours, you can give them activated charcoal, and you can give them even longer than that, 4 to 6 hours, if they have taken sustained release medication. The dosing is, if you're giving single doses, usually the dose is like 50 grams, or you can give them multiple doses with smaller amounts, like a 12.5 to 50 to 25. You have to obviously be careful that the patient is alert, cooperative, there's no nausea, there has to be some bowel sounds present. You don't want the patient to, if the patient to be alert enough to take it if it's not a patient that's already intubated. So the studies are basically mostly on volunteers. There's this one study, I think it's from like 2000s or 1990s, that they took 32 volunteers, they gave them 10 milligram of amlodipine, and then they broke them into different groups, and then they gave them activated charcoal. They gave some of it right after ingestion, 2 hours later, 4 hours later, and 6 hours later. And they saw that up to 2 hours after ingestion, if you give activated charcoal, you can decrease the absorption by about 50%. And if you give it right away, you decrease the absorption by about like 90 to 99%. Another thing that you can do is whole bowel irrigation. Should strongly be considered if the patient has taken more long-acting medication, even up to 4 to 6 hours. I think the recommendation I saw was for verapamil and daltesan sustained release medications. If they have taken more than 10 tablets, you should strongly consider it. So basically, the way that is done is that you basically put polyethylene glycol 1.5 to 2 liters per hour via NG or OG tube, and then continue doing that until basically comes to the other side. As far as, what about calcium? So the evidence behind calcium is 1D, which basically means strongly recommended, but based on very weak evidence, which you will see here. You will see that in most of these basically interventions, this is the best evidence we can get, and for the same reasons that we discussed. Sorry, I had a calcium gluconate and slide 2 over there. Anyway, so it makes sense, right? If the patient took calcium channel blockers, giving them calcium kind of makes sense. And there's also some case series, some case reports, and some animal studies that suggest that this is helpful. It is relatively harmless. You just have to be aware of the dosing that you're giving. So if you're giving calcium chloride, that is generally given to the central line because it can cause like tissue necrosis. The dose is 1 to 2 grams, and you can repeat it every 10 to 20 minutes, depending on how the patient is, how the hemodynamic of the patient changes. If you're giving calcium gluconate, this is generally what we give through the referral line at first. You have to give 3 to 6 grams, and then reassess the patient 10 to 20 minutes later. And if the patient is really responding, you can put them on calcium drips. For calcium gluconate drip, it is around 0.1 gram per kg per hour. So it's like 7 grams per hour for somebody that's like 70 kilos. But like any other like sick with a patient, you want to be at the bedside, like giving these medications and then reassessing them frequently, and whatever works, keeps giving it, basically. And then you have to talk to your pharmacy, both about insulin and calcium drip if you think you're going to give it, and glucagon, which we'll get to pretty early on, because getting these medications or getting these drips are hard. And if you think the first calcium that you gave is working, the second one is working, start having this conversation with the pharmacy that you might want to patient on the calcium chloride drip. I will get to glucagon a little bit later. So
our patient, the patient in this case, they only got 2 grams.
they
of
got
calcium
2
gluconate,
grams.
right?
Yes, yes. They got more calcium later on in the ICU, but in the beginning they got 2 grams,
Of calcium
which is
gluconate.
low of calcium gluconate, which is lower than. But I think when they put the central line, which was a couple of hours later, they also got some calcium chloride, but that first calcium was never repeated. So the rationale behind giving high dose insulin is that calcium channel blockers block insulin release from the pancreas. They also impair uptake of glucose by the cardiac myocytes. So under normal physiologic conditions, the heart mostly prefers using free fatty acids as source of energy. During stress state, it turns to carbohydrate metabolism, and insulin facilitates that. It's also in animal studies, it has shown that, and also on isolated human myocardial models, it has shown that insulin by itself has direct positive inotropic effect and independent of the glucose status. It helps with contractility. So the doses are pretty large. So your first dose is 1 unit per kg of regular insulin, IV bolus, and then 0.5 to 1 unit per kg per hour, and you can titrate it to MAP. So again, somebody that's 70 kilos, that is giving 70 units of insulin to this patient. So you need to talk to your pharmacy, you need to talk to your nurses, kind of get them ready to give this large amount of insulin and not be concerned about if the patient is going to get hyperglycemic. Most of these patients are hyperglycemic, and you're going to give it with glucose, and you're going to put them on glucose drips. So just be mindful of these large doses. A lot of, I think this is what Poison Control recommends, but there are studies that start at 5 units per kg, even with that first bolus, and that start the drip at 5 units per kg per hour. And you can aggressively escalate this. Every 20 minutes, you can add 50% to this. So if you're really, really aggressively going high, by like hour 2 or 3, you will get the max dose of insulin, which is 10 units per kg per hour. So in a 70 kilo person, that's 700 units. So you can pretty aggressively titrate this up based on your MAP, especially if you see that it's effective. You want to obviously give this with glucose. You can give an amp of D50 when you're giving your bolus, or 2 amps, and then you want to give them 35 grams per hour of glucose. What solution you use, D5, D10, or D20, you can use any of them that's at your disposal. However, just be mindful of how many drips these patients are getting, and they're getting massive amounts of fluid. So try to, if you can give like D20, it is a smaller amount of fluid. So the evidence for high dose insulin for patients that have any signs of reduced contractility, which point of care ultrasound is kind of helpful in this, to just have some sort of like baseline EF on these patients, is first line with calcium and some IV fluids. In patients that we do not know what their contractility is, or if they do not have any signs of reduced contractility, it is kind of the recommendation is 2D, so it's like recommended, but not as strongly recommended. And it's also rescue treatment at any point if the patient becomes refractory, you just keep going up the insulin. The evidence behind it, the human evidence behind it is kind of weak. There are 4 studies, most of them, because they're observational, non-randomized studies, most of them retrospective. They mostly talk about the safety profile, and most of them do not show any clinically significant hypoglycemia or hypokalemia that cannot be managed by like aggressive electrolyte and glucose management. So it's a safe, basically, medication. Glucagon definitely has a role in treatment of beta blocker toxicity. So I think in this patient definitely has a role given that they also were beta blockers. However, even in isolation calcium channel blocker toxicities, glucagon still has some role. Again, evidence is kind of low, but there's definitely room to use it. The only downside to it is that it can cause vomiting. Just be cautious if the patient has altered mental status. It's relatively safe overall. Again, it's something that you can try. You can give 5 milligrams bolus, which we have in CCT and PIXA, so it's very easy to just give 5 milligram and just see how the hemodynamics changes. If the patient really responds to it, you can give another 5 milligram, and then if the patient is really responding, maybe you can even put them on the glucagon drip. Just be mindful that the entire hospital glucagon, basically, the entire glucagon that is available in the hospital is probably enough to support 12 hours of glucagon drip. So this is again something to talk to your pharmacy pretty early on. If you think this is working for your patient, just call pharmacy, let them know that you need them to get more glucagon because you're about to put somebody on glucagon drip for a prolonged period of time. What about methylene blue? So methylene blue has also been used mostly in the studies on sepsis, cardiopulmonary bypass, hypotension, post-dialysis. The proposed way that it works is that, so you primarily in calcium channel blockers, especially like amlodipine toxicities, you have vasoplasia, which is nitric oxide mediated, and basically methylene blue kind of reduces the nitric oxide related vasodilation. For calcium channel blockers, the data is mostly limited case reports. The 2 recent case reports I found, one of them, they gave it at different times. One of them gave it at 16 hours, one of them gave it at 8 hours with insulin, one gave it without insulin. So it's not really good evidence. However, it's something to consider and use. Just be careful that if the patient also has like SSRI toxicity, and you give methylene blue, you can at least like theoretically cause serotonin syndrome. So just be aware of other medications that the patient has taken. I'm not going to go into doses because obviously nobody's going to remember it. So as far as pressors, there is no study that basically compares to one pressor versus the other, specifically in calcium channel blocker toxicities. The guidelines recommend norepinephrine to be the first line of pressors. They don't really comment on what your next pressor should be or when it should be added. Obviously, that is something that you can assess the patient for and see if you can look at their EF, and you can look at the volume status, and you can look at your blood pressures and decide what your next pressor is going to be. This is the whole topic, can be another talk, but it's also not just want to go into that because we don't really have time. But norepinephrine is the one that is like a first line. And let's say if you do get an echo on the patient, if you do a bedside echo and you have a decreased EF, then you might want to add something like epinephrine. Avoid dopamine as always because it's arrhythmogenic. And things like, even if these patients are bradycardic, which with amlodipine, they shouldn't be. Atropine and pacing doesn't really work because at that point, if somebody is on calcium channel blocker toxicities and they are bradycardic, it's usually it's not isolated to SA or AV node. The effect of calcium channel blocker on SA or AV node, it is basically every myocyte is poisoned. So pacing then doesn't really work.
Good question. So which do we up titrate first, the high dose insulin or vasopressors? How would you?
I think per evidence, I think insulin, because especially if the patient has contractility issues, that is the one that is, but I think with a lot of treatment in these patients, you're kind of doing all of them at the same time. And that is how the studies are too. Like there's no case report that did one and didn't do any other thing. So it's kind of a hard question to answer, but you can basically do all of them at the same time. But yeah, going up on your insulin gives you more contractility as well. Yes.
I think Wiener would know more, but I think there was like a recent thing where like one of the Arizona programs, they looked at like they don't use high dose insulin glycemic therapy at all, and they just use peripheral pressors, and they're like, we had no like bad outcomes, but it's not a a study.
Yeah.
It's one group and they don't use high-dose insulin therapy.
Yeah, the problem with most of these studies is that they're not comparing one thing versus another thing, and there's just so many things that are not controlled for. So it's really hard to answer. In most of these studies, you can only comment on the safety of the medications. Like we didn't have any bad outcomes, but you can't really comment on how effective one regimen is if you haven't really controlled for anything else. Yeah. Okay, and because JFK is here, roll-up point of care ultrasound. I just put this slide just for you. You should definitely echo these patients at least to get some sense of where their EF is. However, how useful it is to keep echoing them, or how useful it is to use ultrasound to try to guide your resuscitation, there is not much good data on it, but it's important to have to establish your baseline EF, especially if the EF is low. You want to be more aggressive with your insulin, and it can also help you with your pressor choices. But that's again another whole topic itself. We don't usually give intralipids in the ED for these patients because the recommendations for intralipids is for somebody that is in refractory shock despite multiple pressors, multiple other interventions. High dose insulin was already maxed, 3 pressors are on board, and the patient is still unstable. That is where intralipid is recommended, and usually that's the patient that is still in the ED. So this is more of an ICU medication. However, it is recommended. The downside for those patients or for patients who have calcium channel blockers and go into cardiac arrest, it is recommended for that too. So in that sense, it might be more relevant. The downside to it is it can cause pancreatitis and also can clog the ECMO filters if the patient is going on ECMO.
It's in the tox box at downstate.
Sorry, what?
It's in the tox box at downstate.
Your top spots.
We have it in downstate.
What else is it?
Tox box is in
The
the.
tox box.
What
Yeah.
else is it?
It's fun to say also.
Yeah.
Tox box.
Tox box. Let's go to
What else
tox
is
box
it?
after this.
Oh, yeah?
Yeah.
I think Dr. Vina was telling us where the tox box is.
In the medication room at downstate.
What's in it?
Intralipid.
It has a large number of antidotes, and there's a list on the outside of the box of exactly what's contained. Some of the larger things that take up a ton of space aren't in the box; they're in the Pyxis instead. For those things, it says on the list that they're in the Pyxis.
The more you know.
Yeah, tox box. So VA ECMO is kind of like cardiac bypass. They pump blood from the venous side to the arterial side, passing through the oxygenator. It is recommended as a rescue therapy in calcium channel blocker poison patients who present in shock, and they, after all the other treatments are exhausted. There are some case reports on it. There's also an observational study on it. The observational study itself is a retrospective review in 2012. It is hard to comment on it because they took 2 different hospitals, both of them even didn't have ECMO, and then they had a bunch of patients that went into cardiac arrest, and the ones that they put on ECMO survived, but there were only 3 patients. However, having said all of that, ECMO is increasingly used in poisoning, and it is one of the recommendations for overdose to use ECMO, and it's just another level of hemodynamic supports in a patient that all of the other options are exhausted. In our hospitals, because we do not have ECMO, it's just important to think about it and talk about it early on and think about transfers and keep reassessing if this patient is now a candidate for ECMO or not, with the input from poison control, with input from your toxicologist, and think about it early, just because you have to transfer this patient out. You're thinking this patient will benefit from ECMO. So this is like a summary slide of basically your progression of therapies. So if your patient is symptomatic, right off the bat, give IV calcium, give large amounts of IV calcium, use decontamination if needed, if indicated, call poison control early. If they're hypotensive, you can add insulin, add pressors, consider glucagon. If they're get refractory, you can quickly go up on your insulin up to 10 units per kg per hour. and you can add second or third tertiary and third refractory to that intralipids via ECMO. And if they go into cardiac arrest, again, intralipids via ECMO. Actually, most of it good, not good evidence, but most of the evidence that I saw via ECMO, a lot of them were very impressive case reports on patients that went into cardiac arrest and then had good outcomes after via ECMO. So just quickly to go over what happened so far. This was the AD course. So now between our 6 and 11, patient is admitted to MICU, but they're still boarding in the AD. They're getting a little bit more, the patient is still alert, oriented, getting a little more tachypnic. Blood pressure is documented. The last one is 98/46. However, when I was talking to the ED providers, they said that the systolic pressure, most of the ones they saw on the monitor were in like high 70s. Insulin, if the patient is on insulin, it's still pretty low dose, norepinephrine, vasopressin. And MICU plan is to start epinephrine, calcium, intralipid, and increase insulin rate and intubate if worsening tachypnea once the patient comes to MICU. They also talk to ECMO, to Maimonides Center at this point at hour 10, which there's a note saying there will be little benefit from ECMO in pure vasodilatory shock, and Dr. That's the name of the Maimonides doctor, mentioned that patient will not be a candidate for ECMO. So at hour 11, patient arrives in MICU. The vital signs are pretty good, but patients under 2 pressor. Patients alert and oriented, insulin is set, intralipids is started here. I'm a little unclear why they give intralipids here, given the indications that it was for more refractory shock, why it was given here when other options like insulin have not been exhausted yet. It's a little unclear to me. They also give 5 milligrams of glucagon. The labs are notable for some electrolyte abnormalities that they fixed, and white heart is just starting to go lower. From hour 12 to 15, patient is getting more and more tachypnic, tachycardic, hypoxic, insulin is increased, norepinephrine is 30, and then hour 15 code 88 because patients become more hypoxic, restless, agitated, and patients intubated. This is the post-intubation EKG. I don't think we have a lot of time to go into it. And this is the X-ray afterwards. Just looking at it, it looks like maybe aspiration pneumonia, pneumonitis, versus maybe patient went into non-cardiogenic pulmonary edema secondary to calcium channel blockers, which is well documented in the literature. After intubation, patient continues to get worse, has multiple episodes of DSATs to 40s and 50s. They change vent settings a few times. They disconnect the patient from the vent, bag them, comes up a few times to 70s and 80s, but it's still mostly patient is saturating low. They put the patient on Nimbex strip. They hope that would help, but it doesn't. They increase the insulin. They start the epinephrine. They also give hydrocortisone. And they also note that abdomen may be distended. They get the OG tube. They suck a lot of charcoal out. And ECMO is discussed again, which basically the same response is given. And then between hour 25 and 41, patient is getting worse and worse. Sodium bicarbs is started for worsening non-alcoholic acidosis. Respiratory status and saturations are getting worse. At hour 41, patient starts to break down, goes into asystole. At that point, the decision is made that further treatment is futile, given that the patient is on multiple pressors and high dose insulin, and patient is pronounced. This is the summary of the events, just to be up. So my basically conclusions are the same as before. The start, high insulin pretty early on, be aggressive with the titrate up, depending on the hemodynamic status. You can start pressors, consider co-ingestions. You can give trial of glucagon, especially if the blockers are on board. Consider early GI decontamination, especially if patient coming in only 2 hours after ingestion. Call poison control early, and think about the next steps early on, including ECMO, which means transporting patients out. And maybe talk, if you really feel strongly about that this patient needs ECMO, maybe we can talk to multiple centers. At that point, if one center says no, maybe we can call another center. I want to know the thoughts on that, especially the attendings. And that's that. Great.
That was a great talk.
Yeah, what do you
Yeah. What?
What do you Schechter thinks about this?
Oh, I mean, I think I think the treatment of other than not giving enough calcium right off the bat, obviously the insulin waiting on that's a kind of frustrating. I think the guy died, I'm going to guess he died from pulmonary problems that he went into either some sort of ARDS or pulmonary edema. And I think that was why he probably died, that they just couldn't oxygenate him.
Yes.
And maybe something to do with the calcium channel overdose or something else. But just a quick point on charcoal. If you're going to give it, make sure the patient is very awake and alert. And if you think there's any chance you're going to intubate them, think twice about giving it. It really obstructs the airway and makes it very hard to intubate if they've swallowed all this black stuff and everything's kind of black. Not saying not to give it, just keep it in the back of your head if you think this patient's going to come in. And this is just a tough case. I think being glucose is the main antidote to calcium channel block. I'm not glucose. Calcium is the main antidote to calcium channel blocker overdose. And really, you shouldn't just like put 2 grams of calcium gluconate and call it a day. It's something that you should be giving a lot of and redosing. If you're, it's hard to get the central line right away. So if you're going to give the gluconate, make sure you're redosing and giving it out.
You can give calcium chloride through a good peripheral line. I've done it. You just got to make sure it doesn't infiltrate. You can't put it through a 20 butterfly. You have to put in a good angio, but you can give it. And 1 amp of calcium chloride gives you enough push as 3 of calcium gluconate. I always gave, this guy was going to die, I think, but I always gave 2 amps usually of calcium chloride for these. Did I see them die anyway? I've seen them die anyway, but it's worth a shot. That's what I would have started with, calcium.
You use infusions, calcium infusions?
I would give it as boluses when I gave it, and then I would also have just like here, I'd throw in the kitchen sink, and then also give calcium gluconate. After calcium chloride, give glucagon, and then hang a pressor and pray.
So Roshan did those are excellent, but
That's great.
points that I would make are, if you're thinking about giving the charcoal and the person took a significant ingestion, or you're going to do whole bowel irrigation, intubate them, because they are going to aspirate, with the whole bowel irrigation. There's no doubt about it. And I think that this person ended up getting an aspiration pneumonitis, and that complicated, because when they made it to the ICU, they had much better parameters. As far as ECMO, the question you raised about ECMO, I do not know of one case that we transferred out of this hospital for ECMO that survived. Not one. And we lost several people as I was setting them up in the other, in the other facility, like Charlie Mahoney and things like that. So if you're going to do it, you got to contact it early. A lot of centers stabilize the airway. That's what we do. We do the airway. It's almost a shame that this person probably died from aspiration instead of from their intoxication, but it was a lethal intoxication.
Yeah, that was actually written by someone who was in the ICU at the time, that apparently he did aspirate that.
Well, yeah,
It's hard to say if it was aspiration versus like ARDS from like pulmonary edema from the calcium channel blocker. It's kind of hard to say.
No,
right?
I agree,
But
like
then,
at that
yes,
point, but there's
then
that
they
risk.
suctioned out the gastric contents.
yeah, what he died from was actually doesn't really matter, because I think what we really should have done is gotten toxicology to call the center. It's not clear to me that they were understanding that we were transferring the patient for an overdose. Overdoses are, they're metabolized, are reversible, and patients can live even if they're really ill. So I just wonder if we could have leaned on other centers, because that's the only thing that I think would have saved this guy, maybe early decontamination. And what would people think about, like, maybe intubating a little early, even when you didn't need it, maybe to be more aggressive? At what point would you guys have done that? You guys, right away.
Go down the tube. Look,
It's a known
ingestion.
ingestion, right? Known large ingestion.
That's
Anyone else
huge
you think right
ingestion.
away? Because we don't think about intubating these patients for what might happen, right? We don't really do that, right?
I don't know. I don't think I would have intubated them as fast. You make a really good point, and maybe we should think about it. I always have a hard time intubating somebody who's not in that moment, because a lot of times intubation can be just as dangerous as not intubating. for a lot of patients.
Right, but maybe we could have lavaged him, right? We don't really do those things often, but intubate and lavage, right? That's an intervention where, we don't have evidence for it, but maybe that would have, we got some of those tablets out, would have helped them.
Okay. But it seems like Dr.
Anyone else?
Kim wants to make it.
And I was just gonna say what you were saying, which is poison control either would have been able to talk to MIMO if they thought ECMO made sense and said, just take this patient, or they know the ICU doctor is at NYU and they have ECMO and send them there instead of just saying MIMO says no. Poison control wants it, MIMO says no, we're not going to transfer them. And then I'd actually be curious because I would think within 2 hours, like this is a within 2 hour, and even New York City poison control, like Bob Hoffman will argue, large ingestions decrease gastric emptying, and you can, they'll even push for lavage later than the evidence will push for it. And so 2 hours is already within that window of like, you should probably just lavage somebody with a massive overdose, I would think.
So I think we have some also questions and comments from Dr. Kim.
Hey, so this was actually my case. So I wanted to focus mainly on this patient when he arrived in the CCT, but unfortunately it was a very busy shift, so we weren't able to, focus all our energy on him. I had thought that the resident had called poison control initially and ordered all this stuff, so I had put in some initial orders with the hope that, they would put in the insulin and get that started, but unfortunately, again, it was a little busy, so we weren't able to do that. So I ended up calling poison control myself afterwards, and then ordering the insulin drip myself. As far as the calcium, only giving that one dose up front, in my review of the literature, I didn't find that calcium for calcium channel blocker overdoses that are not diltiazem or verapamil to be all that helpful, especially in large ingestions. And already this is a patient that is probably the most nursing labor intensive patient that you'll ever see, especially with the high dose insulin. So when he didn't respond initially to the calcium, I didn't see much of a benefit to continuing a drip or anything like that. But of course we could have given additional doses as well. So the other thing to keep in mind with these is that these patients will get tons of fluid just from the insulin. They will go through bags of insulin, at around 3 units per kg per hour. He was already going through multiple bags of insulin every hour. So I don't know if it's possible, but if we could get pharmacy to get more concentrated bags of insulin or mix larger volumes of it so that they don't have to keep sending us bags, that would actually be really helpful because there is a lag time. We kept calling pharmacy to get the insulin, send multiple bags at once, but there's still times when there was no insulin hanging in between. And that's, obviously not ideal for the patient.
Even hours later in the NICU, they had the same problem. Even hours later, when it was established that this patient is going to be on insulin drug, high doses, while the patient was in NICU, they had difficulty getting, they would go through bags so fast that it was hard to keep the patient on that high dose insulin consistently. That was definitely a barrier in the care.
And another thing is these patients, once they're on the insulin drip, until their glucose stabilizes, they're getting Q15 finger sticks. They're getting 30-minute shocks and BMPs. So this is really like a one nurse at the bedside the entire time patient. So it's really hard from a nursing standpoint as well.
That's what you do.
I think that's really good. I think most of the times when we think about ECMO, the patients are already in extremis. And I think maybe identifying a patient who might benefit from ECMO later on, which is like a large overdose patient like this, might be beneficial because you're not saying, oh, this patient needs ECMO right now. It's we're transferring this patient because there's a decent chance this patient might need ECMO later on. So instead of trying to argue with somebody, you got to put ECMO now, we're going to transfer them because we don't have the resources to provide for this patient if they decompensate from their overdose. And that's really ECMO. And I think MIMO will actually will if the patient needs ECMO now, I think the advantage of the MIMO is that they'll cannulate here prior to the transfer. So it's like the really sick patient who may not survive a transfer. This way they're getting the ECMO and they're going to be transferred on the ECMO which I think is advantageous.
Or
I
they're
think
going
transfers are dangerous.
Or they're going to an ED with better nursing staffing that actually take care of it, too, beforehand.
No, our nurses actually did a really good job with this patient. The nurse like never left his bedside. But what I will say though is that I think when the MICU initially called Mimo for ECMO, because he was still not maxed out on the insulin dose, that was the main reason they didn't take him. If he was already maxed out at that point, then I think they would have considered taking him.
That was at our time.
Yeah, I think more aggressively going
Insulin.
on
The insulin,
an
yeah.
insulin would get you there. The problem was it was hard to get large amounts of insulin and keep the patient on large amounts just by the fact that it was hard to get it from the pharmacy. But yeah,
And then
the first call, the patient was only on 3 or 4 units per kg.
Yeah, okay. We're over. So I just want to make sure everyone can get the
I think
shift.
there's a couple of more questions, but I guess.
Too late.
Send an email, we'll start an email chain.
Great job.
All right, thank you.